Negative experiences with patients, I have had very, very few, because at the end of the day, good or bad outcome, there was trust. I trusted the patient to make the best decision for herself, and she trusted me to say, listen, I'm really uncomfortable with the situation. I think we should do something about it. And the more that I think that we can create that culture, and that doesn't happen without both sides having freedom and the ability to express those concerns and be able to like tell their stories and talking about their horrible experiences with OBs and why they think OBs are terrible. But for the most part, I like leaving those stories up there because they mark me. And I hope somebody reads that and is able to flip a little bit of a switch. Not everybody is going to be able to do that. But if it can happen for me, and if I am open-minded enough to change, I really hope that my colleagues are able to see that we can make a difference, and we do make the difference, for better or worse.
Welcome to the Keeping Your Power Real Talk on Resilience podcast. I'm your host, Traci Dula. I'm a family and birth advocate, a mentor, and your personal encourager. I wanted to create the space for individuals, families, and professionals who are done with just surviving and want to rise. Because when everything feels like it's falling apart, the one thing the world can't take from you is your power. And that's where resilience begins. It's not just riding the waves or surviving the storms. It's about how to overcome the challenges. So whether you're in the thick of it or reflecting on where you've been, pull up a chair and let's navigate the hard conversations and the beautiful stories that together we can be honest and use empathy and have a desire to grow, all while, of course, keeping your power in the process. What happens when an OB becomes pregnant for the very first time and suddenly sees the system that she has worked in through a whole new lens? Dr. Janelle De Jesus joins us for a raw, eye-opening conversation about autonomy, awakening, and the quiet resistance it takes to stay human in a profession that often forgets that we are more than just patients and providers. She's a powerful advocate for women's voices, but even she is navigating the tension between what she was taught and what she now feels. This is a kind of real talk that challenges the norm and reminds us that resilience starts when we choose to think and care differently. Thank you for joining while we hear her share how she's keeping her power in that process. Welcome, Dr. De Jesus. I am so thankful that you're here and really, really excited.
I'm happy to be here, Traci.
I am so excited, number one, because, OBs are humans, and sometimes we don't see the human side of our doctors in general, but especially in the birth space. It's like we see this, maybe just in prenatal appointments or even as a birth worker, just kind of somebody that's in and out, maybe somebody that's on call. And I'm thankful to sit down with you today. I gravitated to you on social media, on TikTok. And I saw a lot of your videos talk about like informed consent and maybe the rights part of it. And of course, that is my foundational root is justice and rights and all of those things. But then I saw you really share a lot personally about yourself.
Yeah.
So how about start with like why you wanted to become an OBGYN?
Yeah, no, for sure. So I actually said, initially I started out medical school. I didn't know what specialty I wanted to go into. But when I started, there were two specialties that I said I absolutely was never going to do. It was OBGYN and pediatrics. OBGYN, like they had put like a C-section on the big screen. It was like this almost like IMAX size picture on the screen. And I was like, yeah, I'm never doing that. And then one of my friends had signed up for a conference where, they were welcoming a lot of medical students and doing a lot of like simulations and talking a lot about the field. And I only wanted to go because it was DC in the springtime. And I know that, I went for giggles basically. And I ended up falling in love with OBGYN and all of the things that they were doing. And then later on in my rotations, I just started realizing like what a unique connection you're able to have with your patients, the things that they bring up during their doctor's visits, the fact that you're able to kind of accompany them from like when they start puberty to when they have a baby to like when they're menopausal potentially. And a lot of those things just like resonated with me and with what I wanted to do. I also stereotypically, I loved the surgical aspect, but I also love that it wasn't purely surgical and that you could have this like primary care level relationship where you're a little bit more like active with your patients.
Yeah, I think that that's kind of what I saw in some of you. It's like, I'm loving doing this thing, but then there's this personal relationship that I get to have to carry people through like this life changing event. So tell me about like that relationship part with you and your patients. Now you just started a new position. So are you private practice? Do you work in the hospital? Tell me how that works.
Yeah. So I was doing locum tenens work, which means I was kind of traveling, basically travel nursing, but for doctors. It got a little exhausting and I'm pregnant, so I had to stay put. I just started a private practice position, which is basically full scope OB. So clinic, elective surgeries, and then being on call, which is like emergency gynecologic surgeries and being on labor and delivery. Yeah.
Right.
It's been a practice now.
Okay. Congratulations on your pregnancy, by the way. But
Thank you.
Before we get there, tell me about your like belief system as far as like the medical model of care in maternity care. Let's talk about before pregnancy, because I'm not going to put words in your mouth, but I think that might have changed a little bit.
Yeah. Before pregnancy, I think most of the experiences that I had with patients was just the experience that I was having with my patients. I mean, other than like in residency, obviously you would see patients with like your attending or your supervising doctor. And so you got a little bit of a sense of like how you wanted to practice and how you absolutely didn't want to practice and everything in between. So that was pretty interesting. But then outside of that, it was very rare that I hadn't had very many personal experiences, believe it or not, with a gynecologist or like with an obstetrician, for instance. And so all I saw from the world of obstetrics and gynecology was the care that I was giving the patient. And the care that I was giving the patient was the care that I thought pretty much like everyone had, like the relationship that I had with my patients, I thought was the one that everyone had. And man, did the tables turn when I got pregnant. Oh my God. It was wow. It was so wow. Just like reversing the experience and experiencing it from a patient perspective. I was like, oh, wow. Okay. So not every OBGYN like, has the same like vibe or personality or method of delivery. And I was like, oh man, which is fine. Like I'm okay with like a difference in personality, but there I found myself having conversations with myself, like, wait, okay, like this is a personality difference, but also there are certain things that are just like unacceptable. And if I'm getting it, and they know that I'm a physician, like I can only imagine what the general population is getting.
So give me an example.
Yeah. So full disclosure, the first time I had found out I was pregnant pretty early, but I thought I was 9 weeks. So I was like, man, I gotta get in to see somebody. So I go in to see an OBGYN, was very, very nervous to do like my ultrasounds and stuff like that. My blood pressure would even come back high. Hello, white coat hypertension. Right. And my husband was like, this is a great thing. Like you're pregnant. We're going to do your first ultrasound. I'm like, babe, remember, cause I had miscarried once before. And I was like, babe, remember, I have yet to have an ultrasound for actually like a good reason. Right. So like every ultrasound that I've gotten previously has been like for something catastrophic. Right. So like, that's all I had. That was the only experience that I had personally. And I go in to see this OB. He does the ultrasound. I ended up having to wait another week because again, it was too early to see any kind of structures on the ultrasound and stuff like that. And so we were thinking, oh, like maybe it's like a blighted ovum or something. Maybe this is not going well. So the next week was just like absolutely agonizing waiting to see him again. So then he does the ultrasound the next time, and we finally hear like heart tones on the baby. You know, we're all obviously like super excited. He tells me my due date. He tells me, well, I'm going to be on vacation like around that time, but probably like you'll end up delivering early because you're an OB, like your pregnancy is going to get complicated. And he was kind of,
so I'm working on my poker face.
yeah, 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 yeah. It was weird because in that moment, like it was 5 minutes, like granted, I'm an OBGYN. Like when we talk to each other, like we're very, very straightforward. Sometimes we can be like really, really dark humored also. Just, it's like a coping mechanism, I guess, amongst us. But in that moment, like he was talking to me like his colleague and not someone who had heard their baby's heart tones for the first time. And
Right.
so I felt like that really, really made a big difference. And I was like, well, and I also felt like that perception of like, you're an OB, you're going to get complicated.
Why would he think that?
Well, there are, believe it or not, there are studies out there that say that doctors do tend to have, we tend to have higher miscarriage rates and we tend to have higher risk pregnancies. So statistically, like he's not like wrong, but it's just like not the environment.
Yeah, don't put me in the clinical category all the way together. Humanize me because I'm a mom who just
right
heard my baby's heart rate.
Yeah. And it's like, read the room. Like, you don't even know if I have your same sense of humor. Like, you don't know if I'm going to be able to handle that. Like, and I mean, normally I totally could, but like in that moment, I was like, man, I just got this vibe that this person was just forever going to be paranoid about my pregnancy because I'm an OBGYN. And actually the stereotype with OBGYNs is that they tend to have the worst pregnancies, the worst outcomes, and like the most interventions.
He was already maybe like PTSD and biased all together. And then on top of that, he's a man. And I feel like a lot of doctors do that. They'll look on the chart and they'll see like what the profession is of that person or, you know, put them in this category and they're like, oh, okay, maybe I need to explain something more. Or even if people have had 2 or 3 babies, they should be treated as that one pregnancy, not that, hey, you don't need to know this. I'm not going to go over this because you've already been through this before because every pregnancy is different. Right.
Exactly.
So how do you feel about where you're giving birth? Like, do you feel pretty good about where you are? Tell me again where you are.
I'm in Puerto Rico.
Okay.
Yeah. So I've been on the labor and delivery unit a few times. I have only gotten kind of like oriented to the labor and delivery unit. It turns out that where I do call is where I will be delivering.
How do you feel about that?
Actually, I feel pretty good about that. I think just overall, it's normally when like funny story yesterday, I fell when I was like evaluating a patient. I went to go sit on a chair and the chair was not there. So I just, I just fell on the ground. And everybody I worked with was no, you absolutely have to do the ultrasound. You have to monitor the baby. I'm like, I didn't hit my belly. I'm fine. They're like, no, you have to. And it's like this new like level of care. I think when people work with you, they've developed a relationship with you and they like really, really care about you and your outcome. So, and it's also really nice just to be able to work with people. I think there's a nice camaraderie that's kind of born of it. When you go through good experiences and when you go through bad experiences, you just like this unspoken sense of camaraderie. So I feel very fortunate to potentially be able to like build that with them before I go through like this big thing. And I also feel like, I hope that like the nurses and the people that end up taking care of me were able to kind of, you know, a lot of people develop like really nice relationships with those people. I'm definitely looking forward to it. It doesn't creep me out, not in the slightest. Maybe pooping in front of them. Yeah, maybe that part.
You've seen my butt.
Right.
So you don't have any concerns or worries about like maybe your specific birth plan and like bias or assumptions of, you know, whoever you work with. I feel like I've had clients and I've had childbirth education students that are, you know, that would be like labor and delivery nurses that were like, no, I'm going to a whole different hospital because I don't want to interact with the people that I work with. So I really love your perspective on that.
So there were like, I switched OBs. I was on my 3rd OB by the time I hit halfway. And the whole reason for that was literally because of that, because I wanted to feel comfortable saying no. And the first couple that I had, I felt like they would be the kind of people to like, I guess, like judge me for pushing back a little bit or saying no. And I also knew, because everyone, all of them are on call at this same hospital. And I also knew like it was a little bit weird for me too, because I was like, well, these people also might be my colleagues, you know, so I don't want to be like a bad seed. It's kind of weird. It's mixing the work and the personal. So I was like, you know, I'd rather go a completely different direction with someone I feel comfortable with.
Yeah. Oh, I totally understand that. I'm kind of, you know, in my life coaching head going, but it's you, it's your baby, it's your birth, that you can do what you want. But I totally understand having to process it all and then transforming into this new human that, you know, on the other side too. And and I don't know if you're new there, like, you know, I don't know if you just started this and you're brand spanking new, but even if you weren't, having to figure out all of that on the personal side.
Yeah, no, 100%. And I was just like, well, I knew, and that was why I would I typically don't go to doctor's appointments telling people that I am a doctor, but like in this specific scenario, I found myself feeling like I needed to tell them because I didn't want, like, there's a lot of C-sections that happen here for failed inductions. Like I wanted them to know that like, I know what you're talking about and it's not going to fly very easily with me. And so like, I just wanted to break the ice right there, like on the spot.
So realizing that you're kind of on this other side as a mom, how have you changed, or have you changed your approach to your own private patients? Because now you're advocating for yourself in a way. So or do you feel like you're kind of coming at it?
Yeah, 100%. I think I think on labor and delivery, I have always been that way. But I think, like I said, once you have a personal experience, the experience, almost like other people's experience, becomes yours. And so even when my patients have perhaps like a request, like I had someone the other day that had very atypical requests for like labor and delivery, and like their intentions were good, but I think their understanding like for what they were asking for wasn't kind of like fully there. So I think that compassion aspect of remembering like they're making this decision for their baby, they might not be fully understanding of the decision that they're making or of the rationale behind the decision, but they are ultimately like their intentions are good. So I think that compassion for them is there. And I think compassion kind of like erases that judgmental component of like, oh, this person, you know what I mean? And and I think also in terms of like how much time I'll spend like explaining to the patient or like just kind of like rallying with the patient. So example, somebody came in with a birth plan. They explained that birth plan with someone who was, I guess, perhaps a little bit like more defensive in their practice. And they were writing all over the note, like they want this in their birth plan, but you know, if like they didn't want Pitocin, but if Pitocin is indicated, it's a non-negotiable. They didn't want a vacuum, but if a vacuum is indicated, it's a non-negotiable. Like they were putting non-negotiables everywhere in the note. And I found it strange because at the end of the day, I feel like this is the only field, maybe I'm a little bit biased, but I feel like this is the only field in medicine where we're allowed to put those things in a note and most people wouldn't bat an eye. Like if I show up to the ER, God forbid, with a ruptured appendix and general surgery says, hey, I need to take out your appendix. And I say, no, you're just going to give me the AMA form and we're going to call it a day.
Right.
Right? Like if I show up with a hemoglobin of 4 in the ER and I need a blood transfusion, and I say, no, you're going to give me the AMA form and we're going to call it a day. But then you come on labor and delivery and people are like, no, well, this is non-negotiable. No, well, we have to do this. No, well, your baby's going to die. No, what? And it's just like, what is the need? And I'll have you know, this patient was like, I don't want an epidural. I don't want Pitocin. I don't want this. I don't want that. And I was like, okay. Like, and at the end of the day, actually, between all of the conversations that we had, I didn't convince her of anything. I didn't go in and try to break her water artificially. I didn't do any of that. She was literally 2 centimeters and she was like, give me the epidural.
Right. So
And
most of that pans out in itself.
yeah, like it literally
Mhm.
fixes itself in
So,
an emergent situation. When you say, hey, your baby's not doing well, I need to put a vacuum on their head. Most parents are going to be like, absolutely, get the
absolutely
baby
get my baby out. Mhm.
right. So like we treat moms like they're totally irrational human beings when at the end of the day, like pretty much everyone is gonna, I've never had someone like, I've had people put on their birth plan, like no C-section, blah, blah, blah. Like I really just don't want a C-section. And the minute I tell them C-section, they're like, oh my God,
Okay.
yeah.
Well, I do think it's about trust too. And I think birth culture in itself is so untrusting here lately. Not even here lately. I've been in this for 26 years and it's just been this walk of standards of practice versus individualized care. And when, you know, when we can look at people giving birth as human beings that need to have a critical thinking process, the education has to be there in order to do that. And I feel like some doctors are just not really good at stopping and getting out of the category of standards of practice for PTSD reasons, for tired reasons, for whatever reason that is. And, or they're just not really good at conversations. I mean, especially when you just have maybe a doctor that wants 10 minutes with their patients and says, hey, this is what I'm saying. This is what we're doing. We just put you on the schedule. And then you have a mom that's calling their doula crying, saying, I don't know what just happened. And I'm like, I don't either, but let's come off a ledge and let's talk about what we know that's factual. And I feel like that just puts a lot of people in a really, really bad space. Why do you think, and you said that, on the chart, you felt like that this doctor was just really defensive in what they were writing. Where do you think that defensiveness comes from?
I think that if I'm being really, really honest from our perspective, I think that really comes from a fear of litigation. And
Mm-hmm.
I'm gonna be honest. It's a very valid fear.
Mm-hmm.
And most, if not all of us, live with that fear. I live with that fear also,
Mm-hmm.
because at the end of the day, you spend 12 years either in school or in training to do this thing where potentially if something goes wrong and it might not even be your fault, you may not ever practice again. And there are a lot of cases where you read about them and they're pretty scary because you're just like, I would have done a lot of the same things. The doctor didn't do anything wrong. And the
Right.
patient still ends up getting, a large settlement, insurance payouts. And then a lot of people don't know this, but when you have a case on your back that maybe you didn't lose your license over, malpractice insurance becomes more expensive. A lot of people will drop OB altogether because they cannot afford malpractice insurance because the premiums are so high.
Mm-hmm.
So it's like
Mm-hmm.
you spend all of this time, these loans, these sleepless nights to literally afford a job, to afford to work.
Mm-hmm. Right.
Which is, I think, a perspective that like a lot of people don't get. However, I don't necessarily think that the solution is kind of like tying your patients down to one decision. Like, in my opinion, and my favorite thing in the world to do is like, I'm just like, whenever I get a patient that's just like a little bit more like rigid in their thinking, like whatever ideas I present to them, I make it sound like it was their idea. Because eventually it's going to end up being their idea because you're just like, it's either A or B.
Right.
Which would you like? Eventually they just get to a conclusion where you're just like, okay, well, like you basically allow them to get to that decision on their own. If they're stable and the baby's stable, there's no reason to not give them the time of day to be able to make their own decision.
Right. The critical thinking is the ability or the opportunity to critical think through your care with the presentation of yes and no, right? That's informed consent, education and consent or refusal. We'll talk about that in a minute. But with this fear that you feel like, doctors have, and that is very valid. Super valid. My mom had her best friend was an OB GYN who actually, there was a case against her years and years and years ago. The family won. It's super valid. I totally get it. But I feel like, as humans, when we run on fear, that makes things even worse and it trickles down to the patient. So I feel like reducing that fear needs to happen, or there needs to be more accountability for that spectrum of, hey, instead of practicing so harshly under the standard or the policy. Let's do the work here first, continuing education or documenting or not being neglectful, because I feel like fear can cause mistakes.
I agree. I absolutely agree. And I think another thing though that we're seeing a lot of, which can be really, really, I think it can be a little bit discouraging also, is the amount of like misinformation people will take and make their decisions based off of. And I think if we, as the people receiving that and as the people having to combat that, if you can't regulate that underlying frustration and judgment that you feel, if you can't regulate that, you're not going to be able to find common ground with the patient. There's going to be this underlying level of judgment always. They're going to feel it because they're not dumb. Our patients are very emotionally intelligent people.
Especially being pregnant. We have way deeper intuition.
Yeah, 100%. And so if you can't keep that in check, if you cannot keep like an open mind when it comes to that, and I get it, it's so frustrating. I've seen people go online and say the most out there stuff. And sometimes even I have to find myself like getting off social media and I'm like, I can't believe that people do this. But if that's something that you're experiencing every single day, I think that leads to like also a lot of like burnout and frustration on the physician's the physician's part.
Yeah. Yeah. I mean, even as a doula, I'm just like combating. There's just so many nuanced conversations that we're talking about. And because there's so much frustration when it comes to, okay, this is my job. This is what I'm responsible for. And here are the things that I'm trying to get done. And this is a great segue into a video that I saw you do. And I even kind of I green screened and commentated it on when you said, not all doulas, but some doulas, and the frustration of counseling a patient and then, maybe leaving and the doula, you use the words recounseled, which I had never really had that language in my head. And being a doula mentor, I went with the mentor part of that video because I can see, or in my philosophy, I'm a team builder in the workshops that I do for doulas, the Keeping Your Power for Doulas. It's really about communication and making sure that we are communicating the situation with everyone in the room and then making sure that the patient has a safe space to think about that. And if they want time, then they can ask for time or, hey, can I have a little moment? There is this part of birth culture where that's why I want to have the deeper conversations about this because OBs are going to get frustrated when doulas have, that potentially stronger relationship, but then we have a responsibility to not undo the relationship between the patient and their doctor. In that video, I felt your frustration going back to, it was that fear that I feel like you were like, look, if you're going to go in there and undo what I just did with my patient, look at where it gets me. But ultimately, it is the decision of the patient. And I will say that, no matter what that relationship is between patient and doula, if a patient's going to change their minds, it's like a whole nother roundtable discussion. Okay, let's get doc back in here. How do you feel about it now? Well, I feel this way about it now. Okay, doc, how do you feel about it now? And they're not being this like at odds. That's why I feel like everybody needs to be, in one space, and there doesn't need to be this exception unless the patient asks for, hey, you got to get out of my, like, I can't think for just a second, just get everybody, out of my space. So give me a little bit more about your experiences with doulas, because I feel like that when I saw that you had like a specific experience with them.
I would say over 90 to 95% of my experiences with doulas have been fantastic. And sometimes when the patient's pushing, I just look at the doula like, especially now that I'm pregnant, I'm like, I would so hire you.
Great.
I would so hire you. And so I would say 90 to 95% of my experiences with doulas have been incredible, amazing. The experiences that I've had with doulas that have not been so great, I think if I had to guess, and the vibe that I get is there are times where personal beliefs and personal biases kind of like overshadow your view. So like when I see a patient from like a different background, let's say like a Muslim patient, like I know she's going to prefer female nurses. I know that she's going to have a preference for certain things. I know also that, you know, if male partner is around, male partner is also probably going to be very heavily involved in her care. And those are like very cultural kind of aspects of, you know, and that's the norm for them. I think that sometimes that these biases can get in the way of like, you know, you've walked in the room, barely introduced yourself, and already there's like a tone in which they speak to you, a tone in which, you know, they'll be questioning, let's say, your management. You haven't even gotten to the explanation yet. And like they already have 1,001 questions when you're mid-sentence and you're like, whoa, where is this coming from? And I have seen it online where doulas will comment like, maybe they've had horrible experiences with OBGYNs. And the truth of the matter is these things, like they do shape your experience. And if you're in it, especially if you're in a rural area with not that many OBs, those are the only OBs that you've ever had an experience with. And if they're all horrible, then I'm sorry, like that's how stereotypes form. It has gotten so bad to the point where the patient isn't even kind of speaking. The doula was speaking for the patient. And I get it, you know, the patient and the doula they've spoken about their preferences and stuff like that. But it's like in the middle of an emergency, like that is not the time for you to start micromanaging me on my like management of a patient. And like at the end of the day, respectfully, but if I'm counseling a patient for surgery or something emergent, like that's a conversation legally that's happening between me and the patient. So like I'm happy to answer the patient's questions and stuff like that, but like when you're interjecting, it gets very, very difficult, and it gets in the way of like patient care and stuff like that. And so, but I will say one thing that I have seen the 90 to 95% do, they're very much a part of the patient's care without demanding so much attention to themselves. When they talk, like in terms of like the patient care, one thing that I've seen them do a lot is like, oh, like, you know, I had talked to a patient about like elective induction versus like her coming back in labor. And she's, you know, she went after I was done talking, she goes and she asked the patient, she's like, well, what do you want to do? Do you want to think about it? You know, like, and then she turns to me, she's like, you know, do you think she can have some time to like think about it? Like she wasn't necessarily speaking on behalf of the patient. She was really advocating for the patient to get her time. Or like when I presented different options in management when that patient was in labor, you know, she would talk about like the different options and ask the patient like, okay, so like which one are you leaning towards based off of like what we talked about were your priorities? It wasn't just like, I'm going to spew off all of the information that I've ever read about what you're talking about. It was kind of like the conversation was directed towards the patient in order for her to be empowered to make her own decisions. And I've really appreciated when they do that, because it leaves the power and the decision-making capacity to the patient. Like I firmly believe that the job of a doula is not to make decisions on behalf of the patient, which sometimes like those lines get excruciatingly blurred based off of like patient personalities. Like some people are a little bit like more soft spoken by default, and they find someone that they can trust and they're like, well, what would you do? And then the doula makes it their labor or their birth. But I think the best doulas are able to like navigate those like conversations. And to be honest, paternalistic OBGYNs are going to exist. They're going to exist everywhere. They're not going to stop babies. And I think that is where doulas have the biggest opportunity in terms of like understanding that this is a game of like personality. And if you can master that, you're going to be the best doula in the world. Like you're going to be able to navigate a conversation between someone who's like a little on the paternalistic side and like managing a patient who's like in labor and feeling super vulnerable. And the way to navigate those conversations is not by like questioning someone and getting super hard on the defensive. Like that's probably how your patient's already feeling. You don't want to feel like this is a fight. You want to get answers at the end of the day. And so being able to facilitate that, I think is just going to be.
So give me an example of a doula that you said interjected when you were trying to give some kind of management and they interjected. So give me an example of what that means. Cause I know the nuanced conversations that doulas have.
In one specific circumstance, the patient had said in her birth plan that she didn't want postpartum Pitocin.
Mm-hmm.
She's, and it's cool, great, fine. It's not standard of care, but also if you don't have that much bleed, like it wouldn't concern me much. Now, if you become, a fountain, Niagara Falls, and, that's one of the first drugs I'm going to reach for, and so this patient was Niagara Fallsing it there with literally my hand in her uterus talking about different options. She said, absolutely no postpartum Pitocin. And I'm like, and it gets really frustrating because I'm just like looking back at her and like, the angry part of me is like, why am I trying to justify my management of this patient? This patient hasn't even opened her mouth, but she's back here and I don't have a legal, moral, medical, or ethical responsibility to this person.
As doulas, we should not be taking a birth plan or the things that we get out of our clients, hey, how do you see this birth? Or how do you want this birth to go? Or here are the standards of practice. Would you like this? Would you like more education on this? So A, B, and C, do you want postpartum Pitocin? Well, that's a spectrum. Hopefully doulas and childbirth educators that are, in these prenatal appointments, which I'm just going to throw this out there, should not be trying to childbirth educate if you are doulaing, unless you are a childbirth educator and are doing an entire series of childbirth education, because we can't give all of that information. So it shouldn't be just this checklist of, do you want this or do you want this? Because labor and birth is boss.
Yeah.
So I feel like, some OBs are seeing doulas that are just like, nope, I'm going to advocate for everything that's on that birth plan.
Yeah.
And that's not a conversation. That's building the animosity of, well, what do you mean? Because I understand that she might not have wanted it in the first place, but now she probably needs it because she's bleeding out. Just having my mentoring hat, on, I know it's, frustrating for you in that moment, but what happened? What did you say to her, or did you say anything to her?
I believe in that instance, we ended up just offering different medications that weren't Pitocin. And then I think eventually she did say yes. The patient ended up saying yes.
Yeah. See, that was good. Good job.
Yeah. It's fun.
It's hard. The birth world is just hard.
Yeah, it absolutely is, because I really understand, like, if people take the time to understand the history behind what obstetrics and gynecology is and how a lot of that paternalism that was there still is very much, you would think, oh no, like that was a long time ago. They were experimenting on slaves and all of this stuff. You're like, yeah, it might have been a long time ago, but we're sure not acting like it. Historically, people definitely have a reason not to trust, OBGYNs. And it does make me happy though, that there is a little bit more of a balance between male and female OBGYNs, just because I think sometimes, you can connect a little bit more, and minorities as well, because at the end of the day, as a minority and as a female in medicine, you have the ability to connect a little bit more with the experience, and the experience has been yours, and you know what it feels like to be, on the opposite side of that. And especially minorities, like you understand a little bit of the history and why, for instance, someone would choose a doctor of color or a doctor who's of a similar kind of culture.
Have you ever been in a situation where you were advocating for a patient with a colleague and it didn't go well?
There was a patient who, it was a stroke alert in the ER. So they thought the patient, essentially a stroke alert happens when anybody thinks that someone's having a stroke. It's a very quick process. Like they get to CT, they get to MRI very, very quickly, and they're evaluated very, very fast. And what I find is, just in general, a very common stereotype, I think, in medicine is people are very, very much afraid of pregnant patients, or sometimes just even female patients as a whole. Like if they have any gynecologic concern, they're like, oh my God, call the gynecologist. So she was postmenopausal, and granted, yes, she was having like some vaginal bleeding, but they're like, we're really, really concerned about this vaginal bleeding. I'm like, is this a stroke patient that you're talking about? And they're like, yeah. And I was like, oh, like, is she soaking through her clothes? Because with the level of the concern that they called me about the bleeding, I was like, she must be like hemorrhaging. They're like, no. And so I look in the computer, I said, I'm not seeing like, because if you're concerned that someone's bleeding, the first thing you do is get a set of vitals to make sure they're not tanking their pressures or they're tachycardic or showing signs of stress. I said, I'm not seeing like the vitals in the computer. Does she have a set of vitals, like recent vitals that were done on her? Like if we're concerned about bleeding, maybe we should start like a transfusion while I'm on my way down there. He said, no, I don't have a set of vitals. You can come check the set of vitals yourself when you come down and assess the patient. Mind you, it's a stroke alert. Like we have much bigger, if she's not bleeding heavily, we have much bigger fish to fry, because the stroke can kill her like a lot faster than her bleeding from her uterus. So I go down there, everything's like fine with the patient, whatever. I was a resident at that point. I looked at my attending. I was like, you're going to get written up today, and I want you to know that it was me talking to this attending. But just like overall, sometimes if I get like a pregnant patient in the ER, there was another one who, we were concerned about a pulmonary embolism. She had all these risk factors. She was pregnant. She was a smoker. I think she had like higher BMI. She had a history of blood clots. She was just like the perfect combination and then she was on oxygen. Like she wasn't able to even finish her sentences. And they were like, well, we don't want to do the scan. The scan has radiation. I'm like, if it's indicated, you should do it, because if she dies, then the baby isn't gonna survive. And bad combination. Dead mom is bad for baby. She was showing all this sign. They basically did every test but the CT, which was indicated at that time. Like I said, like she was needing oxygen. Like this is pretty serious. And like the echo was showing signs of like a clot as well. And I was like, listen. And then they said they called a consult. And I think it was like a routine. You have routine consults and you have stat consults, which are like, come see the patient now. It was a routine consult to evaluate the patient to see if she needed heparin because she was pregnant and we didn't want to give her heparin. And I was like, this is like something like anybody can find this online. Like if she's pregnant and she needs heparin, even if your scan was negative and you're suspecting that she's still having a clot, you can still give her the heparin because it could potentially save her life. And people were just like, no, like, let's just call OB and see if it's okay to do this. And it's like, this is time sensitive stuff. And it just, a lot of the times it kind of feels like, she's pregnant. Let's see what OB has to say. And it's like, oh, save her life. Save her life.
You feel like you weren't being listened to because like a certain hierarchy that was happening?
I don't necessarily think it was a hierarchy in this case. I think it was more so just the stereotype of, she's pregnant. I'm going to wait around for someone to tell me that indicated management is okay. Like I'm just going to wait for obstetrics to give me permission to save this patient's life.
Wow.
Because she's pregnant. And that I find happens quite a bit. I think people just in general, even in medicine, I think sometimes people can be a little bit afraid, understandably so. Like the most vulnerable patient population, and it was women and babies, right? So like they can be scary for sure.
Well, I know when we go through the ER, they're like, Traci, get her upstairs. We are not baby in here. I'm like, look, if a baby's coming out, all you're doing is catching.
Yeah, that part. Yeah, for sure.
It's funny how ER people that do trauma all the time. I'm like, y'all could put somebody's ear back on, but you can't catch a baby. Like, just completely blows my mind. So funny. So funny.
Yeah, it is really, really funny.
Yeah. Well, tell me how your pregnancy's going. Like, what I know inquiring minds are going to want to know. Like, what are your plans for birth, and like, how is your pregnancy going?
Pregnancy is going super duper well, I have to say. First trimester was not fun. Like the nausea and the vomiting, that was not fun. But then second trimester was definitely a glow up for me. I try not to be super open about that on social media because I don't want to like rub it in anybody's face who's having like a bad time. But second trimester was definitely the glow up. Third trimester is starting to get like a little bit uncomfortable, but overall, like I'm really enjoying like my belly and stuff like that. But I've just been really, when it comes to the pregnancy, I've just been really in a space of like protecting my peace and protecting my energy and like just being happy on my own and like not saying too much about it. Cause if I involve other people, like I was just at my sister's wedding a few weeks ago, and all the commentary about like my body, like my breasts were so big, my belly was too big for my gestational age. Someone literally saw me in the hotel lobby and like lifted my shirt. They were so excited. And I'm like, this is literally assault. And I hate this. And like people like touching my belly without permission, which I thought I would absolutely love. And I hate it. But overall, I think I've just been like in a space of like trying to protect my peace and my happiness. I'm like, no one is more happy than me about the fact that I'm almost like 200 pounds. I don't even care. I love my belly. I love like all of the stuff that like my body is able to do. I just discovered I can lactate now. I'm like, oh my God, like look at me go. And every time I see an ultrasound, I'm like, look at my kiddo. And like every little experience, I've been giving myself like the grace, the space, and the time to just like enjoy it as a first time mom and not as an OB at all. That's the only thing I found out that our baby does have cleft lip and palate. So that was a little bit of like an emotional kind of roller coaster for me, mostly because of like the surgeries and stuff like that. Like he's going to need surgery at like 10 weeks and 10 months. And the idea of like seeing a baby that's not even like a year old or a few months old under general, just like absolutely kills me. I've never had surgery before. And so I feel like I experienced that first. And I feel like, and that was that day of the anatomy scan, I was like, man, I hope everything goes well. Like there's probably no greater gift to a parent than having to never or not see more doctors than you need to. I remember thinking that the day of the anatomy scan, and then we got that diagnosis and I was like, oh my God. But overall, like I love our care team. My pediatrician is the one that we chose as like a lactation specialist, and
fabulous.
Yeah. And the plastic surgeon was wonderful, but like, it's been great. Like honestly, it's been wonderful.
Well, I want to encourage you. My oldest son had open heart surgery at 2 months, and he was born with tetralogy of Fallot and had open heart surgery. And I didn't think that I would survive it either. It feels very heavy to see your child, with all the wires out and intubated and all that things. But talk about resilience and finding like that strength to go through all of that and think, wow, I'm just never going to be able to do this, as a parent. But I was thankful for our care team and the things that they can do now. Is just absolutely amazing to me. So you'll dig deep. It'll be good. Feel your feelings, grieve the loss of whatever you thought was supposed to happen and move forward. And you're going to do great. If you can do all the things that we just talked about and switch kind of that mindset from, oh, this is what I thought my OB identity was supposed to be. And oh, now I'm seeing a new light because you're in it. You know, and that's what I love about just having a lot of conversations with OBs too, is we just have to remain teachable in our lives. And, you know, I'm not, I'm not just a doula. And so I want, other people in the birth team, you're not just an OB. You are, a mom, and you're a friend, and you are listening to these people that might not ever get the time with someone else. And I'm so thankful, and I'm kind of seeing it in real time with you and in your space. I love knowing you, and I just thank you for being here with me today and sitting down with me. Thank you for sharing, and I can't wait to hear some updates about your baby. And I'm gonna continue to stalk you on social media.
Thank you. Oh, wait. And you asked me too about my birth plan.
Yeah.
I don't know that I super have one, to be honest with you.
You need to.
I'll call them preferences.
Yeah. So let's talk about what I really do with my students. Think about your own belief system. You've got to separate your profession from your personal beliefs. And that's really, really hard. Take some time. And that's why I kind of asked you ahead of time, because it takes time to say, no, this is me in my OB identity, but now in my mommy identity, really, what do I really want in this experience? And what do I really believe needs to happen to me and my baby? Now, that takes maybe even some therapy around, or some deprogramming, so we can get together with your husband, because it's like, how do I even wrap my head around all the things that I know? Because you know too much.
Oh my God. Yeah. 100%.
You've seen too much.
100%.
So kind of take it there. Don't take the standards of practice. That's not what I'm talking about. I'm not talking about, are you going to deny an IV, or are you going to ask for intermittent monitoring? That's not what I'm going to ask, because you might want all the bells and whistles just because you do know all the things.
Yeah.
It's about kind of getting to the root of what makes you feel the safest in this scenario. And that's what's going to progress your labor if you decide to go into spontaneous labor.
I feel like I have the stuff that I want, in the back of my mind. I'm very hyper aware of my values and stuff like that. But I've also been very, very intentional, I guess, of trying not to be too rigid with it, and understanding that anything can happen at any moment. So for me, my ideal in my mind is showing up to the hospital anywhere from I don't know, 4 to 6 centimeters, maybe not going I guess immediately to the hospital if I can, if no issues arise.
Well, girl, that's everybody's ideal.
I know, right?
I've been education for years, and that's everything. Tell me what you want. I just want to pull up, and I want there to be time to get my questions answered, to be admitted, and for my progression, and just rock and roll and be there for about 5 hours. That's everybody's answer.
Yeah.
And it can happen, but let's hold space for that. Let's hold space for that. And that can happen, but that has to be prep and really good childbirth education, as far as let's talk about what spontaneous labor looks like. So different than managing high risk birth, especially for yourself. But also, I want to encourage you too, not to think about being rigid. And I understand what you mean, because you're probably thinking about your patients too. Don't think about the plan. Don't be rigid. Okay, let's take rigid out of the conversation and think, I am going to ask for what I know I need. I am worth it. My baby is worth it. I'm going to ask for what I need, and I'm going to say no for what I don't need. And honestly, that's not rigid. Yes, we're going to go with the flow, but we're absolutely going to uphold our own agency and autonomy.
Yeah. No, I love that.
Yeah. That's where resilience comes in. Yeah.
Yeah. And I feel like and that's part of the reason why I'm on social media, is I feel like I'm on social media for my patients as much as I am on social media for my colleagues. Because I have also realized I have been influenced by both patients and my colleagues online as to listen, what if we weren't this way, or what if we were more this way?
Right.
And listening to people's very, very personal experiences with their OBs, and just having personal experience with it. I haven't had all good outcomes for all of my patients. It's virtually impossible to do that.
Right.
However, I will say for the most part, negative experiences with patients, I have had very, very few, because at the end of the day, good or bad outcome, there was trust. There was trust on both sides. Like I trusted the patient to make the best decision for herself, and she trusted me to say, listen, I'm really uncomfortable with the situation. I think we should do something about it. And so the more that I think that we can create that culture, and that doesn't happen without both sides having the freedom and the ability to express those concerns and be able to like tell their stories. And, sometimes it's a little bit hard for me because I'll find patients like maybe like trauma dumping a little bit on my page, just like talking about their horrible experiences with OBs and why they think OBs are terrible.
Yeah.
And I really do as much. I mean, if it's disrespectful, like I'll just block. But for the most part, like I like leaving those stories up there because they really do like they mark me. And I hope somebody reads that and is able to like flip a little bit of a switch, like not everybody is going to be able to do that, but if it can happen for me, and if I am open-minded enough to change some of my views and some of my practices on the basis of this, like when people talk about how these experiences affect them, I really hope that like my colleagues are able to see that like, we can make the difference, and we do make the difference for better or worse. And so we need to keep telling these stories, and there needs to be more physicians and just people in the birth space in general, online, I think.
Yes.
Yeah.
Wonder Twin powers activate. We are going to go out and do our things on social media. And again, Janelle, I just am super thankful for you being in this, birth space and educating with me and being teachable along, with me, and just being self-aware and, hey, if there's anything that I can do for you, let me know. And super excited about your pregnancy. Keep me updated. And maybe you can come back after and say, hey, this is how mommyhood's doing.
Oh my God, yes. I'll give you all the tea.
Yes, give me all the tea. Okay.
I might be in tears, but
all the tears. We'll cry together. Okay. Bye.
Bye. Thank you.
Thank you for spending time with me today. If you follow me on TikTok at Traci Doula 4 or Instagram at Traci Doula, you know how I like to dig into the deep conversations. If you don't follow me on those places, you should, as well as this podcast. As we lean into honest conversations, especially the hard ones, remember that your journey has power and your healing lights the way for others. The work you're doing ripples further than you know. If you'd like to work with me, whether it's coaching or childbirth classes or workshops if you're a professional, or mentoring, or maybe even speaking at an event, visit tracidoula.com. And if today's conversation spoke to you, I'd like to hear your thoughts. Reach out anytime through email at hello@tracidoula.com, and feel free to leave a comment. Until next time, move forward with intention and keep your power in the process.